Thanks so much, Lee. Good morning, everyone. This event was already worth doing for the people that have gathered in the room this morning. Really, really glad to see so many of you here on relatively short notice in the middle of the summer. But this is a really unique gathering of folks who are both in positions to impact the way that we support children and families in DC, and that also have what I think is a healthy degree of dissatisfaction with how things are now, and really are motivated and inspired to do better. I really want to thank Aspen, as Lee said, particularly thank Marjorie and James and Kimberly and Lori and Ann for their support in helping to pull together this event, helping to pull so many of us together. So as Marjorie said in her introduction, that Aspen's expertise, or one of the expertises at Aspen, is having the right conversation at the right time. And I think we feel really strongly this is the right conversation for DC right now. So many of us, I see folks in the room that are involved in healthcare and in education and in philanthropy and in social services and in justice. And I think all of us are thinking about the ways in which mental health, brain health, social, emotional well-being of children and families is not what it could or should be among our friends, neighbors, colleagues, communities in DC, and we want to and can do better. And when one of the other things that Aspen does extraordinarily well, I'm learning, is some of us might think we have networks. Aspen has a network, capital N, actually capital letters all the way through. And so when Lee and I started speaking with Lori and with James and with Kimberly in the spring about the idea of some sort of a series of convenings that might inspire the kind of collective action and change that we think is really needed in DC around children and family health and well-being, the capital N network was activated. And we're all going to benefit from that today. So really, really glad to introduce colleagues who have done systems thinking, systems design, human-centered work, and also transformative work in places that are far away, but I think that are going to have immediate resonance with the folks in this room as relevant to things that we want to try to accomplish in DC. So we're going to hear from Barbara Martin about Colorado and the work that they've done at a state level, which is an inspiring example, I think, of bringing together stakeholders, agencies, health systems and hospitals, and thought leadership to create real transformation. And then we're going to hear from Sydney and Kat from Austin. And I encourage everyone to please look into your folders and look at people's very impressive biographies, which I will not do justice to from the podium. So instead, please review the biographies. But Kat and Sydney are here from Austin, and what's happened in Austin, beginning out of Austin State Hospital, but really extending into a regional model of what healthcare for people with challenges related to brain health can look like on a region that they'll describe the extent of the region and the extent of the transformation that's taking place. And it's powerful, powerful stuff. So we're going to hear from each example for about 40 minutes or so. We'll do our best to stay more or less faithful to the time. And we will, I promise, have time to ask questions and to reflect and to do some back and forth a little later this morning. But at this point, I'd like to turn it over to Barbara to tell us about Colorado.
Great, thank you, Matt. And it sounds like you can hear me because I can hear myself. Thanks so much for having me today. My name is Barbara Martin. I direct the Colorado State Innovation Model Office. We are housed out of the governor's office. And a little background about the State Innovation Model, or SIM. We are a 4-year federally funded initiative. Colorado was funded $65 million by the Center for Medicare and Medicaid Innovation to transform our delivery system supported by payment reform. Many of you are familiar with SIM. It was a very ambitious and really one of the largest initiatives that came out of CMMI that really recognized that states and districts can be the petri dish for change and really enable us to understand what works and what can drive systems change. One of the challenges with that is that every state has different issues and needs to identify those issues. But at the time, CMMI really recognized that states were the ones that could solve some of our hardest healthcare challenges. When Colorado was embarking on the SIM initiative, like all states, the proposal had to come from the governor's office. We had to show that we had far and wide sweeping support. At the time of the proposal in 2014, we had recently received a lot of our local public health agency needs assessments that were required as part of the Affordable Care Act. 2/3 of our counties in Colorado identified mental health and substance use disorders as the number 1 and 2 unmet needs in their communities. So it was really a galvanizing opportunity that state leadership and community partners and individuals in those communities all came together and recognized that opportunity to move something forward that could truly be transformative. Our proposal was to create a coordinated, accountable system of care that provides Coloradans access to integrated primary care and behavioral health in the setting of the patient's medical home, recognizing that that might look different for individuals and families. For most individuals, they would seek care in their primary care setting, but we certainly recognize that our community mental health center in Colorado is also an area that is of significant value to our partners and our individuals that seek care there. The goal, as you'll see, is to serve 80% of Coloradans by 2019. And the reason why I want to acknowledge that is because that setting out in 2014, 2015 was almost an impossible goal to try and reach 80% of Coloradans in 4 years. And that's a little bit of my story that I'm here to tell you today, because we are at the end of our 4-year journey, and yet our work feels like it's just begun. And one of the important lessons learned from a leadership perspective and a state perspective is how do you maintain a vision and a goal, but also identify clear, measurable milestones that individuals, stakeholders, community partners can see their role in impacting and can see the measurement across time. And that's one of the, I think, a lesson learned that we didn't have when we embarked on this journey in 2014, 2015. And without those clear, measurable goals, people were often reverting back to the how are we going to get 80%? And it sounded so impossible that it was almost paralyzing to many of our stakeholders. And so part of the story I'll tell here today is how we had to double back on some of our efforts and make sure that we were bringing all of our stakeholders and partners along with us to develop a true system of care. As you noted, we really were focused on the primary care system, identifying that systems of care are necessary across a continuum, and we wanted to make sure that we were building a broad swath to capture individuals at the place they were most likely to receive care, to identify opportunities for prevention, systematic screening, and to build the public will that mental health and substance use disorder need to be treated just as much as physical health disorders. We had 4 pillars. I love this slide. My communications team hates it, but we've had it for like 6 years, so I won't give it up. But payment reform, practice transformation, population health, and health information technology. Underlying each of these are consumer engagement policy, workforce, and education, or evaluation, that really interweave within our pillars. If we had to do it over again, I would make workforce probably this whole house. Right? Workforce development and supporting the behavioral health workforce is so integral to all of the work that you are setting out to do. I'm sure Austin has done and that we've done. We recognize without adequate, reimbursed, prepared workforce, we will never get where we want to be. So as I just put this up here, I won't belabor it, but of course our goal even back in 2014, 2015 was to focus on the triple aim by having goals within the payment reform, practice transformation, population health, and health information technology spheres that we would influence to improve health outcomes. And since then, of course, we've included the care team well-being as well, and now look to the quadruple aim. So how was it that Colorado set out for this ambitious goal of integrating behavioral health into physical health care supported by value-based payment models? What does that look like, and what do we need to do? When I was looking at this slide, I decided that we just stopped putting people up there because the smart art wouldn't let us add anyone else, but really there's so many more people that were engaged in this initiative. We contracted with every single state agency that touches healthcare, Department of Human Services, Department of Public Health, our Medicaid office, our Office of Behavioral Health, We have the Division of Insurance and every other health cabinet member on our advisory board. We have public, the funders in Colorado were engaged in SIM. We have the university, our Health Information Exchange, our all-payer claims database, our membership organization for mental health and substance use disorder organizations. All of these partners not only came together with the vision, but also became our contracted partners, which has its challenge, because once you start into a contract, trying to manage 20 different high-profile contracts to gear everyone towards a singular vision, you often get stuck in the details of the contract rather than maintaining the vision. So one of the challenges is, how do you keep that vision, have clear milestones, but also have accountability to your partners? Because this initiative was started in 2014 with the vision from the governor's office, but that's a long time ago. That's a lifetime ago for policymakers and state agencies. And there's a lot of other priorities that have come in the interim that could divert attention away from our focus of building a system that's integrating behavioral health. How did we do that? The most effective thing we did is we built a coordinated structure. The SIM office that I direct was created by executive order. It was mandated who would be on the advisory board, and we were required to have these work groups meet on a regular basis. This was actually a requirement from CMMI, but we're told that we're really one of the only states that actually truly did this in a meaningful way. And we just had our last steering committee meeting last week, and they were just as engaged and invested in the work and how we move it forward as they were in the beginning. And these groups are where we held ourselves accountable, where we held our partners accountable, where we maintained transparency in the business decisions that we had to make. So the governance and engagement process is essential to identify in the beginning. Once you've identified what is your goal for transforming your system of care, what are your milestones, how are each of these, or whatever your work groups or structure, how are they going to inform your ultimate outcomes? One of the biggest decisions that Colorado made that was a little bit unique from other states in our SIM initiative in developing a system of care is our multi-payer approach. We decided early on we did not want to just be a Medicaid initiative. Of course, Medicaid had to be a participant in order for a state to be awarded a SIM fund. But we wanted we wanted across the continuum. We wanted to know, what was it like to engage commercial payers in paying differently for behavioral health and paying for the value of what you could provide when you integrate systems of care. And of course, I'm talking about primary care, but it translates to any system of care, as we know with the juvenile justice and any other foster care. You know, you're looking at some of the most complex systems that you're trying to bring together. So our lessons of how we fold in new partners can really help speak to the challenges and opportunities. These partners and these payers still participate in SIM. We have our last multi-payer collaborative next week, and things that were important to them were these four: aligning quality measures, common approach to accountability, data sharing, enhanced financial support. Those sound great, but you don't see integration in any of those words. You don't see behavioral health as the focus. So we had a big challenge in deciding to engage our commercial plans of recognizing that the federal government is expecting us to transform delivery system. Colorado identified the need to integrate behavioral health because we knew we would not improve outcomes or reduce cost of care if we didn't. But that created a tremendous lift on our part, because it would have been much easier just to say, you know, we're going to focus on physical health care and let's have at it. But we really embarked on a new journey, and we enabled the commercial plans to recognize and do a look in the mirror from their perspective to see how faulty their systems were at really serving children, youth, families, and adults. They recognized that just like our state Medicaid office, they had bifurcated administrative systems serving physical and behavioral health care that didn't even talk to each other. And so it was a pretty rude awakening for many partners in the state of how many silos we had. I will just say briefly, before I go quickly into our pillars, our Medicaid office at the time that SIM took off, we had our physical health care was fee for service. and our behavioral health care was capitated. We have 7 regional collaborative care organizations at the time that are the administrative entities, but they don't bear any risk. Since that time, we've gone through a new request for a proposal for new partners to manage those 7 regions. And while it remains fee-for-service on physical health care and capitated on the behavioral health care, we've pulled out 6 behavioral health care visits that can occur in the primary care setting before the individual has to enter the specialty mental health care system with the CCAR and all of the work that's entailed in entering a new system of care. So in many ways, that's been a step forward that our Medicaid office, on top of supporting our practices with incentive payments, has also changed the way they reimburse for behavioral health to incentivize treatment in the more upstream primary care setting. Recognizing 6 visits isn't going to treat most people with any significant diagnosis of mental health, but it can treat those that require upstream episodic intervention, and then can make sure that there's a warm handoff for individuals that require a referral to our specialty mental health care center. So one of the biggest things that we had to do was figure out, how do you bring together these 2 different cultures of physical health care providers and primary care providers? And the same would hold true for any system of care that you're trying to develop. It's a significant culture clash that requires leadership and recognition that each practice looks different, and you need to start with those relationships. And so that's very much much of our funding went to support practice transformation and coaches in the practices with the behavioral health workforce, identifying ways to bring together those 2 different entities. We've pulled in approximately 25% of primary care practices have now participated in our SIM initiative, and we have a bidirectional health home pilot with 4 of our community mental health centers that is overseen by our membership organization. So as I mentioned, it takes a village, and we have pretty much everyone under contract in this initiative. Okay, so what about the children? When am I going to start talking about that? Here I am. So one of the things early on, I said that we had our funders were supportive of SIM. There's a lot of energy behind SIM. Our early childhood mental health funders came to us and they said, you know what, we'll fund the convening of your payer organization for 1 year only, but there's a stipulation. You have to have at least 30% of your practices be pediatric or family practice serving kids. So it really created a culture early on that this initiative was not going to be focused on adults. It was not going to be focused on those typical chronic disease patients only. We really wanted to make sure across a continuum of care. And we have really honored that and have a robust, probably the biggest opportunity for our pediatric and family practice providers to develop systems of care upstream to get the screening, referral processes in place, identify what behavioral health partners that they can partner with, and to also identify what that culture needs to look like. And so I can't emphasize enough how much different partners and influence and the politics of what's important to different partners is so necessary to recognize and catalyze and capitalize on in order to move some of these systems of care forward. The small grants were another opportunity from our funders, and our Colorado Health Foundation provided $3 million in funding. These were enormously helpful because they gave flexibility to our practices to use these grant funds in ways that you can't use federal dollars. And by and large, many of them used it for patient and family engagement and developing those systems of connecting better with their families, as well as hiring behavioral health providers. We can't use our funds to pay for services, just they're infrastructure dollars. So these dollars were a catalyst for our practices. And this is an example, you know, the change, it's incremental and it's small change and it feels like it's baby steps, but this huge initiative ended up being successful because we had practices that were willing to take their creative ideas and use our funding to catalyze and move forward work that would help their community. So Western Colorado has significant challenges in this community with parents and having the right, this was very much a 2-gen driven funding opportunity that this practice used to really identify ways to better connect their patients in the community by going out into the community. So that's just an example of how our practices have capitalized on this. So I've gone through this really quick. We are at the end of our 4-year initiative. We are finishing next week. Our office will close. And so I'm a little reflectful here, and also don't want to bore you with a lot of the sausage making that's occurred in the last 4 years. I want to make sure we have time for questions. But what's really important, we set out to integrate behavioral health into primary care. What we found quickly is when you look at the Medicaid program and our commercial plans, they weren't ready to support a fully integrated model of care for all of our practices. In fact, when you talk to our commercial plans today, they say every one of our 25% of primary care practices in Colorado looks different in terms of how they're doing integration. And part of that is because it was so new, and because the challenges were so unique to each community, depending on the workforce available, depending on the resources, that we had to enable some type of flexibility. But it also created some challenges because we are now 4 years into this initiative with 25% of primary care practices having different models and looks of integration. When we want to move this to the next step, we've spent the last year trying to identify, okay, what does that look like moving forward? How can we institutionalize this work to ensure that we do not lose this foundation that we have built? We have the commercial payers still engaged. They see the value of integrating behavioral health, of better addressing these needs. How do we make sure we take it from a kitchen table approach of it looks different and that serves the needs of the patients to these are the things you have to have in place to ensure you have that system of care. And I think you all are uniquely poised in looking at your children and youth system to recognize that you need, how do you build that flexibility, but also ensure that there's a stable enough foundation. Someone asked me though a month ago, would you have done it differently? Would you have created more structure? Which we did in the middle. I haven't gone through all the rework we had to do to create more defined milestones for the practices, for the payers, for our stakeholders. And I think that was probably as far as we could have gotten for where we were at in implementation and where our practices are at. Because at the end of the day, it's practices that are serving patients that are taking time off from that to change the system of care. And as a nurse practitioner, I can appreciate acutely how much energy that takes, how much it requires leadership and a culture of change that's hard to build from the outside. It has to come from the inside. So when you look at what was it that our providers did that enabled them to better develop systems of care around integration, they're just, incremental steps that can be taken, but in totality, when you start to see that 25% of primary care practices have taken steps to develop systems of care that include behavioral health, we're starting to see a culture shift and a culture change. And I was going to start with my funny joke that we've been through like 2 natural disasters and 55 man-made disasters since we started. There has been so much change. The federal government has changed. They came out with new initiatives that directly competed with our initiative. We've had a new state leadership change. This was a Governor Hickenlooper priority. This was his back in 2013. So in order to maintain the momentum and the engagement, we've had all new executive directors in our state agencies. We have fatigue across all of our contracted partners. How do you maintain that energy? It is imperative to continue to move these types of initiatives forward. So I'm going to, we did do a lot of work with our clinician and staff survey that I'm happy to talk about later, but I wanted to just talk a little bit about what happened. How did this build the foundation that can lead us to a children and youth system of care? I think I have 3 minutes left, maybe 1. So about a year ago, in May 2018, our Children's Hospital of Colorado embarked on a roadmap. How many people have 25 roadmaps in their state right now? It's like the word of the day. But they embarked on a roadmap to develop a behavioral health system of care for children. Many of the same stakeholders, we were engaged. It was a real transfer of, we focused on integration in primary care. How do we take this further using a systems of care approach? They had work groups based on all of the, domains of the systems of care framework. They developed a very tight timeline of 6 months because they wanted to identify recommendations and get to the next legislative session. And when Lori and Matt and I were talking last fall, I was mentioning some pipe dream of a legislation that I never thought would happen about building a system of care for children and youth. And sure enough, 9 months later, this system of care that was originally envisioned after that roadmap work to be an office out of the governor's office to build the system for the high-risk children and youth. Well, it's not in the governor's office. It's in our healthcare policy and financing, which is our Medicaid office, but it mandates that they work with our Office of Behavioral Health that has the block grant funding, and it actually gives money for positions, and it creates a steering committee. This actually happened in our legislative session, and you have a list in your folder of all of the legislation that passed this year that is actually phenomenal, and SIM is listed in several of those legislations as the foundation of why we need to continue to build and focus on integrating across the continuum of care. So we now have a new office that's being created that puts funding for our Medicaid office has 2 people for behavioral health and substance use disorder before this funding became available. And it now requires that they partner statutorily with our other agencies that work in the same population. At the same time, there's a new behavioral health task force with our Department of Human Services requiring that they overhaul our entire behavioral health care system. And again, focused on building off of the work of SIM. So I think I've got 1 minute. I'm going to stop so we can ask questions. This is a really big whirlwind of what we've accomplished, but I think one of the take-homes is we started in one area, behavioral health and primary care. We've had a lot of ups and downs, but we always maintain that momentum and that leadership and the stakeholder buy-in because of our stakeholder process and our engagement with the transparent and I think an authentic process of bringing our stakeholders with us, and it enabled building from that. So we now have so many things moving forward that will better address the behavioral health and substance use disorder needs of children and youth and build that system of care. And so, I'm thrilled to see that this is where we ended. I didn't think it would happen when Lori and I met. It's amazing what a legislative session and a change in administration can do sometimes. So. Anyhow, I want to stop. I've got a lot more slides that if anyone's ever interested. Oh, this is just so.
Super. Thank you. Awesome. So, Barbara, it's a whirlwind, as you said, and it's an enormous body of work that you all have carried off over the last 4 years. I'm going to take the prerogative of being provincial and trying to apply it to DC. And so I guess one question that I have, and I think others will have related questions, is going back to how you started with the fact that were you to do it over again, you would want to think about milestones, intermediary milestones that would build towards your long-term, really, really aggressive and ambitious goal. What would, if you were time traveled back 4 years and able to set those up from the outset, what would those milestones have been? And what would you recommend to another jurisdiction that was thinking about, if we were to set some sort of North Star, like you did, 80% of practices and kids served, or sorry, citizens served, Coloradans served. What would some of those milestones have been?
That's a great question. And I think one example, the work I'm most proud of is actually our population health work, which we were in over half of our counties working on stigma reduction campaigns and improving access to behavioral health systems, recognizing that our community partners are best served to really meet the needs of the population they serve. And one of the things that we didn't do was connect the dots and ensure that everyone was not only working towards that same vision, but also saw what their role was in achieving that vision. So our statement is, integrate these systems of care by 2019. And I started to ask people, well, what does it mean? What will we get if we do integrate behavioral health, right? How will we know we're successful? And so we embarked on this journey with our steering committee and our work groups to redesign our logic model based on that. What do we need to see by 2019 so that we can achieve this vision by 2030? And one of the biggest examples was recognizing that we needed that North Star, and then we needed measures underneath that. And suicide, we are one of the worst states in suicide rates and have significant gaps in any services and supports for high-risk populations, including middle-aged men, which is our highest risk population. So recognizing that we need to create milestones that our community mental health centers, our local public health agencies, and our primary care practices saw that they all had a different role that they could play in addressing that state almost unattainable goal of reducing our suicide rate. Mm-hmm. So we started by working with our steering committee to distill down what does it mean to impact suicide rates in the day-to-day work of our community mental health centers, our public health agencies, and our practices. Mm-hmm. And I was told by one practice coach, well, our practices, our providers aren't doing this to impact suicide rates. And I said, oh, I have more faith in our providers than you do. They absolutely are. They're doing this to better address the needs of the patients that they serve. And they see that connection with population health and practice level interventions. So hopefully that's not a distinct, these are the 5 things Sure. you guys should do, but that's an example of how we had to distill it down. So our milestones were very much built into our contracts of how our practices, how would our practice coaches help our practices make sure that they were able to screen mothers for maternal depression, screen kids for developmental screening, which I could talk to you guys about for an hour here, screen for everyone for depression screening, and so they started reporting that data. How do we know that the local public health agency stigma campaign is actually hitting people? Like, get numbers, because I tell you, CMMI came out after our 2nd year, and we had this wonderful conversation with one of our public health agencies, our Let's Talk Colorado campaign. It's amazing. It's an app for messaging for people that are potentially at risk for mental health crises. And they said, okay, what's the number? How do you know you've touched the health system? How do you know you've reduced cost of care? And our public health agencies were like, what? What are they talking about? We don't measure our impact in that way. And I reiterate all the time, you better start, because if we want to continue to see funding in our communities and to address and to engage community partners and population health efforts, we need to understand, how do we know that we've had an impact from that investment? How does it touch the health system? Because unfortunately, that's how we measure outcomes. So it's really in looking at what are we measuring, what would happen if we integrated care? And those are some of the questions that just, I'm sure they got discussed, but they weren't put down in paper. So,
thank you. Can I open up to folks in the audience, questions that you might have for Barbara? Yes, I can see that. Oh, hi, Laura.
Thanks for a great presentation. I actually have 2 questions if we have time. One was, I noticed that you had said about 70% of your practices elected more aggressive screening practices for selected conditions. I'm just wondering who performed the screening and how was it paid for in the context of thinking forward beyond grant funding for sustainability? My second question was, you mentioned 6 visits that were authorized within the primary care setting. Was there any thought around women during the prenatal period, and now we're looking at the postpartum period up to 1 year, to try to maintain that co-location during that particular, prenatal to postpartum continuum?
Those are great questions. And the screening systems really are the most important, I think. We've all had the bad screening where someone's disinterested in asking you, are you depressed? Are you having a bad day? When you go to see your provider. And so the most important part of the screening is that it is authentic. And some of our practices use a tablet. We found that for adolescents, that's really helpful. They'd rather use technology to answer some screening questions than be asked in person. Some practices use their MA, their nurse. They have it built into the EHR, the check-in process, so it looked different. And we didn't mandate which evidence-based screeners practices needed to use, which in retrospect, I think that would be moving forward. We're in a different space today and could make some recommendations. For example, we're now looking at our depression screening because it doesn't include a question about suicide ideation. So how do we go back to all of these practices and say, we know you built a system with the PHQ, can you add this new evidence-based screener? So I would recommend that there is some clear guidance on what are the evidence-based screening, and to the extent that you can build systems of care that use technology that perhaps enable funding from the state. Certainly we try to use 90-10 funding, health high-tech funding whenever we could. to think about what are those investments in technology that could be standardized across the system that could help our providers more seamlessly provide this. And our screening is reimbursed by Medicaid and some of the commercial plans. And you'll see in your packet, we have a mental health parity law that just passed on top of mental health parity. This one is a specific putting some teeth behind mental health parity that ensures that screening is covered. It's pretty amazing. And again, we are proud that we had some role in building this legislation that really seeks to ensure that Medicaid and the commercial plans are really providing mental health services at the same level that they would for physical health care. So that's just past this session. But a lot of people don't bill for the screeners for Medicaid because they just don't think it's worth it. It's $10 for screening. And so our rates from the EHR actually for screening are much higher than the claims-based rates because they're doing it. They just don't take the time to bill. And then I have to say, but it is money, you know, and it is available. And if you're looking to sustain this, don't we want to make sure we're capitalizing in it on everything?
Yes.
So maybe you were touching on this already when you mentioned the suicide issue, but were there particular actual health outcomes that you were able to look at during this course of your 5 years?
That is a great question. We are finished next week, our implementation. And I was telling Lori, for some ill-designed reason, our evaluation is also due next week. I would never advise that ever for anyone. So our evaluators are scrambling right now to pull together the claims and cost and utilization and clinical data. With our population health data, our public health surveillance, we've been very clear because our public health agency has been clear from the beginning. You might not see movement in 2, 4, 5 years in your suicide rates because of this work. And so when we readjusted our milestones, we made that in our logic model. In 2030, we want to see the suicide reduction rate reduced because of this work. And if we can integrate care in these practices by 2019 and then continue to, you know, achieve X, Y, and Z, then we will achieve that by 2030. But I will tell you that from the outset, you have to identify what are we going to impact? What are those outcomes that we can stand proudly here and say we will have an impact on? Because that was something we did after the fact. You know, we just have our measures are run-of-the-mill, you know, diabetes, hypertension, obesity, and then our depression screening, hospitalizations for psychiatric and regular physical health care conditions. We just kind of threw it all in a pot and said, well, we think if we better address behavioral health issues in the primary care setting, we will impact all of these. And when you got back to the provider, that's a big lift for them. They're like, you want us to reduce total cost of care in 2 years and impact every single one of these when all I'm trying to do is figure out how I contract with that behavioral health provider, what codes I can use, how I can maximize care coordination dollars. So putting that all together, it has to start with, yeah, we have buy-in from our stakeholders that these are the measures that will be moved by developing that system of care.
Can you talk about your value-based purchasing options around young children and in the pediatric setting?
Oh yeah, I wanted to say that. Yes. So we did have our funders put together a pediatric, we funded a pediatric population health position and convened a lot of our practices and early childhood mental health funders to look at what are value-based models for pediatrics. And I definitely went to bat for, you know, integrated models of care are hard to sustain without adequate funding. I would say if you had to prioritize what makes the most sense for a fully integrated care where you're not relying on codes, you can have a warm handoff, it's in the pediatric setting, right? It's the generational approach where the behavioral health provider can just step in a well visit and see how things are going and make sure that they have those pieces in place for a healthy, thriving life. And so pretty early on, people started coming to me and said, oh, what about the health and behavioral codes? Can you just get those added to the 6 visits? Because you still need a diagnosis for those 6 visits. And of course, when I went to my Medicaid colleagues to talk about the health and behavior codes, They're like, oh my gosh, we've been hearing about those codes for 5 years. You know, it's almost like people had already beaten it down so much that they didn't even want to listen to it. So we tried to think of what are different ways we can get creative outside of just a pay for performance incentive on top of fee for service. And our funders are currently funding a model development around pediatric value-based purchasing that includes evidence-based interventions, not just integration, of course, but the early childhood, I can't remember what it's called, but there's an evidence-based program in the primary care setting. So that's still to come, and yeah, it's not an easy feat because we remain fee for service. And then of course, a lot of the work, you know, when you look at young kids in the Medicaid program, you have the EPSDT, and a lot of times it's like, well, there's so much that's covered. That's a comprehensive visit. Why would you need anything else? You can cover it all within that. I'm seeing all these heads nod here. So how do you, oh boy, you know, and then we can get to the conversation of, well, you're not going to see the improved health outcomes for the family or reduced cost of care until after the kiddo might be off Medicaid. So who's seeing the value of that investment? We've seen it all and heard it all for pediatrics. And we didn't crack the nut, but that was the one place that I tried significantly to work with our state leadership to look at models of care.
That's a highly germane issue for us in DC, where there are opportunities to do. I think what you're describing is sort of is a pilot effort around value-based payment.
Yeah, exactly. Yes.
Is it geographically located or within a certain with a particular payer, or how is the pilot defined?
So I think that it would definitely be pilot based on our regional accountable entity. So within one administrative function, getting an engaged administrative partner of our Medicaid program. And I will say that our state foundations have gone through leadership and priority changes. So we've also had to, I'm just thinking right now, because that priority is funded by a foundation that's currently going through a new strategic planning process and might no longer be interested in health. So, you know, how do you capitalize when people are interested in a timely fashion? But yes, it's a pilot, and of course it would include, you know, we looked quite a bit at a bundled payment and what would that look like. Our Medicaid program is looking at bundled episodes of care for maternity, which we currently don't do, but actually looking at that whole person. I think I didn't answer someone's question about maternity, but how do we ensure that there's also mental health as part of that 10-month bundle and then postpartum? So there is a lot of work, but it's early stages.
Okay, great. We have time maybe for one more question for Barbara. Yes, Sarah.
Could you speak to if and how family and community voice was integrated into your work, either at the state and or local practice levels?
Yes, so I would, and I don't know why I'm doing that. I would say that our practices were where we learned a tremendous amount. One of our building blocks for practices did require that they have patient and family engagement in some way. And I didn't bring the slide, but I think most practices started out with a survey. But then we started to see a shift in the last 2 years to patient family advisory councils, where the voice of the patient and the family started to be at the table, invited as true partners in decision making, which looks different based on the practice and their willingness to really give that voice to the family. We learned a lot from our state Medicaid program because they have a very robust patient and family engagement council, and recognized early on in our advisory board, we had 2 consumer representative advocacy positions, but we didn't have a consumer. We missed the consumer voice. And so we worked with our, again, work groups and identified 2 consumers that were engaged. Actually, they came to us from practices, and one sat on our steering committee and one ended up sitting on our advisory board for the last year. We had to get our statute changed to add that person to our advisory board. So it felt a little bit like too little too late. We had our consumer engagement work group, but it was fits and starts. They couldn't really figure out what their role was, and we recognized we just need consumers and that consumer voice. And we need to recognize that consumer advocate organizations play a key role, but they don't always represent the voice of the consumer in the community. So once we got those voices at the advisory board at the highest level, And then within the practice, that's where we started to pull the information of how is this impacting you and what can we do differently. So again, would do it much more structured and from the beginning, truly engaging consumers in how you're designing and implementing a program is key. And we did it the opposite way.
I saw one other hand. I think we can spin. Was that Caroline? Was that you with one other question? Sure.
Particularly from the insurance companies? And then also, to your point about policy, do you have recommendations for states looking to replicate this model, make it sustainable? Do you think getting that buy-in from the governor's office is crucial, or do you think legislative initiatives are also important for sustainability?
Oh, that's a great question. So our health insurance programs, we have a robust. Oh, sure. So how did we engage the commercial, the health plans, insurance companies, and then also what's the lever? What moves the needle? Is it governor's office gravitas, or is it legislation that's required? So we have a really robust multi-payer collaborative that the commercial plans and public payers came together before SIM, and we were invited to participate when SIM was funded. They meet monthly, and you would think it's the most important meeting in the world because everyone wants to get to that meeting. In fact, I just met with one of the health plans last week, and I said, Mark, do you realize how much political capital I've spent keeping people at bay and protecting the space you all have to discuss alignment and work together to the extent that you can given antitrust laws? And he's like, what are you talking about? He had no idea that, our 140 stakeholders that meet regularly all wanted to go to the multi-payer collaborative and hear what the payers are saying. Because when it comes down to it, it's how things are paid for that dictates the systems we have in place. And there is this feeling from many of our stakeholders, if I could just talk to them, they would see the value of why they need to pay this way. And it doesn't work like that. Most of our health plans are national. We started out, we had 12 major health plans in Colorado. By the time SIM's done, we have 6. We've seen mergers and acquisitions and consolidation just like everyone else. What it comes down to, we created a multi-stakeholder symposium, providers and payers. That's it, no one else. They come together, it was quarterly during the time of SIM, and they talk and they develop partnerships and they recognize we're serving the same population. Our members are your patients. Let's work together to identify common outcomes that we want to achieve. What are you looking for? What am I looking for? We got our payers to sign off on our building block milestones for our practices, saying this is what we expect out of high primary care. This is when we'll start negotiating with them differently, when we see these things. Because we were finding that we didn't know, and without knowing, our practices were just going in blind to some of this work. So we developed guardrails of this is what you need to do to be successful. Here's an opportunity to talk to them. And then maintaining this multi-payer collaborative with a neutral facilitator meeting on a regular basis. So they will continue on. They voted to continue on post-SIM. They will also continue these multi-stakeholder symposiums, which we're very proud of. And they're starting to look at specialty care. We have another initiative I oversee, TCPI, that includes 2,000 providers, all specialists. 500 of them are behavioral health providers. So we're trying to work with the commercial plans because we think, although by and large it's the Medicaid population that we are most concerned about, if we can bring the commercial plans, that's when you get that culture shift and the 25% of primary care, and then people are calling their legislators saying, we want this kind of care. Does the governor's office, certainly being from the governor's office helped. I could convene a conversation, I could call a meeting, I could do all of those things, but at the end of the day, it's this legislation around building a family and children and youth system of care that will stick. It's now statutorily required. And so I think we spent 3 years in partnerships and using the governor's office leadership, but that laid the foundation that others were then able to use that window of opportunity to pursue legislation for mental health parity. We have enhanced primary care reimbursement bill that just passed, so primary care will be reimbursed, and integration and SIM is listed in there. We have the mental health parity, SIM is listed. We have the behavioral health system, SIM is listed. So I think we were just that catalyst for a lot of other things because we were one small part of a whole system supporting behavioral health. So But I think you need the legislation. Just saying.
Super. Strong point. And thank you so much, Barbara. Really appreciate that overview. You have a lot more to teach us, so you're gonna get a lot of curbside consultations at coffee break. So we're gonna shift a little bit south and a little bit east to Texas, and hear about the work that's going on in Austin, where the medical school has an Institute for Health Design, which is something the first that I've ever heard of that. So we expect to be inspired. So Kat and Sydney, please take it away.
Great, thanks. So we're really glad to be here. I have to say, I grew up in the DC area, and I grew up, not thinking you could learn much from Texas. So I'm glad that you invited us to come here. So thank you for having us. It's great to be back and to share some of this case study with you. Like Matt said, I'm Kat, and I am from a group that I'll talk a little bit more about within our new medical school called the Design Institute for Health, and Sydney's with the Department of Psychiatry, leading this redesign project that we're both working on. So I want to give you a little bit of background first about the context of what's going on in Austin, so that you can understand a little bit more about this case study that we'll take you through in the work that we are a year and a half into. First of all, I need to take you back to 2012, when in Austin we had a countywide proposition that was going to increase our property tax. And know that in Texas we don't have state income tax, so increasing the property tax is a pretty big deal, because that's the main way that we make money for the government. So there was a proposition that was put out by a man who at that time was a Austin mayor and now is a state senator named Kirk Watson, who I'll talk about. But he had laid out this idea about a new property tax that would increase property taxes by roughly 38%. It was a lot. It was 5 cents for every $100 of property. It was a big increase. It passed by 55% vote. And what that enabled was a durable revenue stream that funded a new public hospital in our county, which desperately needed to be rebuilt. It also funded a new medical school, which is the one we're now coming from, which I'll explain to you. And it funded a unique payer, which is our healthcare district for the county. Texas did not expand Medicaid, so we're Texas. But Travis County, which is in Austin, which are often called the blueberry and the tomato soup of Texas, has this really unique payer, so that if you live in Travis County, we actually have a program called MAP, which is Medical Access Program, funded by this tax that actually pays for all the safety net and uninsured in our county. So you have to understand that a little bit, so that this new property tax actually generates $35 million a year to fund the medical school that we're at, and that is part of it. What's also incredibly unique about that is that rarely are medical schools tied to their community that way. So usually, you think of academic medical centers, and of course they do things with the community, but they're not like by mission, by funding, tied to the health of their own community. So that's an incredibly different setup for this medical school. We are, I'm mainly going to talk about that because the medical school is such a different setup. These are some of the folks that led to that. In the upper left is Senator Kirk Watson, who's been instrumental in what I just spoke about, and also in the project that we're going to take you through. When the new medical school received that funding and a lot of matching funding from the University of Texas at Austin, as well as from a number of other foundations to start, we first recruited our amazing dean, Clay Johnston, who is the man just below Kirk Watson here on the left. We will graduate our first class of medical students this spring, so we were only 4 or 5 years old. We are the first new medical school in the United States in 50 years at a Tier 1 research university. So part of what comes with that obligation is really understanding that part of what we're trying to do is literally rethink everything. I mean, this is a medical school where we've said, if we're going to do this, we cannot continue to be part of the brokenness of the system. We cannot be part of, everything has to change. Everything has to change. We have to think of this medical school as a place to actually create the leaders who are going to change the system. They will be physicians, but they have to be physician leaders, and they have to change the system. So that's part of why there's a design institute, because Clay early on had worked with a lot of designers in his career, and a lot of design-led, design thinking groups who said, how do we really convene a number of different types of entities to come together and use design methodology to reframe, very stuck problems and find a way to actually move them forward. So one of the first things he did was create the Design Institute for Health, which I come from. And we are a collaboration between the College of Fine Arts and the medical school, which is also another thing you don't usually see. So that's Clay. And Clay also brought to Dell Med Steve Strakowski, who's the gentleman in the larger picture there. He's our chair of psychiatry. And Steve also had a bold vision that when he came, he said, I want to be part of rethinking everything that has to do with what he likes to call brain health. I'll talk about that language in a moment, too. So this is really how this project that we're going to talk to you about came to be. It's important to know kind of some of that background around Dell Med and around a design-led approach and also even about Austin and our unique payer. Everything at the medical school, I won't go through that case study, that'd be another hour of how we've completely changed the curriculum. Our clinics are only value-based and integrated person-centered care. They only have integrated practice units. We did not take on running the hospital because we do not want to be part of that financial model. We're making our money in completely different ways. So it's a very different model and a very different medical school. And that's part of why when the state was looking at redesigning its state system of public psychiatric care and the 10 state-run inpatient psychiatric hospitals that are literally falling apart, and they said we have to rebuild them. That was part of why when the legislature, the 85th legislature, so 2 years ago, mandated that Austin was one of the state hospitals, one of the 10 in our state, that had to be completely rebuilt. It was just literally falling apart and had to be rebuilt. And that was an opportunity that came to Dell Medical School, that came to Steve to lead that redesign for that region. And that's some of what we're going to talk to you about today. So that's part of that beginning. I'll let you go from there, Sydney.
Thanks, Kat. So as Kat was saying, Texas has been investing in mental health for several years now. In 2011, Senator Kirk Watson made 10 goals in 10 years, one of them being the Dell Medical School, and then another one making mental health a priority in the Central Texas area. In November of 2014, the legislature also funded a report called the Cannon Report, which we've mentioned in our report. And the Austin State Hospital has about 50% of the buildings in critical or very poor condition and needing to be torn down and rebuilt. So what came of that? Yes, we are building a hospital, but the conversation then turned to, if we're going to build a brand new hospital, let's build a system that can support world-class care for brain health. In 2014 and 2015, that's when the Dell Medical School opened, and Dean Clay Johnson started, and we are now having our first class this spring. And then fast forward 2 years, we received the $15.5 million for pre-planning and planning of the Austin State Hospital redesign. And with that, we took a look at our whole entire system that we have, looked at our gaps, our opportunities for improvement, and gathered several people at the table. So in March of 2018, we created our steering committee, similar to what Colorado did. We had stakeholders from local mental health authorities, which is kind of our safety net outpatient area, for mental health, intellectual developmental disabilities, early childhood intervention, autism. Some of them even also provide primary care. We had local government come to the table, law enforcement, the legal system. We had a strong peer support voice for family and peers, and then also local and not-for-profit and private partners come to help us find these gaps in areas and support us in these efforts. And in December, it was a quick dash, 10 months is all we were given to write the report and do our research. So we submitted that to the Health and Human Services to review everything that we learned in our system.
One of the things, too, I'm going to jump in and say
go
is
ahead.
that Texas legislature only meets every other year. So
we have timelines.
it's part of the smallness of our government. And we only meet every other year. So since this is legislatively funded, it's really important to hit those sessions.
Thanks. Yes, we have timelines. So this January, our 86th legislative session began, and HHSC, Health and Human Services, took our report to the session and looked at all of our recommendations that we recommended to change in the health system, and we'll touch base on that here shortly. Just this past May, it closed. We didn't have a special session, so sometimes that can play. If we have a special session, it pushes us to August, which is what happened in the 85th session, which is why we only got 10 months to write a report. And we received $165 million to complete the next phase, which is building the Austin State Hospital redesign facility. In October, we'll begin our early construction package. And in July, we will complete the early construction and begin building the hospital that we are all working towards right now. And then in January 2021, we will go back to session because we did not receive the full funding that we requested this past session. So we will have to request more, and there are other changes in the policies that we would like to recommend to continue in the support of the system that needs to change. And by March 2023, we will have a brand new hospital that will be opening. So this is the current hospital. The building is not where our individuals are served. That is the original Austin State Hospital built in 1867. It will not be torn down. It's on the National Register list, Historical Register list. But if you can see, I don't know if I have a pointer, but there are two squares here on the far left-hand side, and these are right-hand side, sorry. Those are the two adult psychiatric hospital units that we currently have, and then what we call the hashtag is the specialty and geriatric unit. And then across the road there, 45th, I realize from
On the
Austin,
very
so
right side.
the very other side is the children. So we have a total of 4 hospitals, and our goal is within the Austin State Hospital that we're redesigned currently, it's going to become one for all of the 3 adult hospitals that we're currently operating. So those will all merge to one operations, which is very significant and exciting. Just to show you where we're working in our service area, the whole highlighted area is the service area for the Austin State Hospital. In total, that's 75 counties for children, and so that's your lime green, which goes across the whole entire shaded area. 57 counties for adolescents, so that's your mint green, and then the dark green included, and then the dark green is our 38 counties for adult, children, and adolescents. And very tiny center there is Travis County, which is where the Austin State Hospital is located. The other stars on the map, just to kind of show that there are other state hospitals near us, but because of how our service area is laid out, if they're in our shaded area, most likely they're going to be coming to the Austin State Hospital. So at times they will pass other hospitals because of the way the map is laid out. There's also the rectangular squares. I know you can't read the names, but those are community hospitals where, because of the payer system and how individuals get into a state hospital, because most of the times they don't have a payer to pay for private, those are the other community and private hospitals that they also pass. So in our research throughout the 10 months, we found we have adults and then we have adolescents, and you can see the shaded areas are their service areas that that Austin State Hospital supports, but the dots with lines showcases all of the individuals that are coming across the state of Texas. So even though we have these service areas, we can't follow them. And one of that is because there are not enough beds to provide care for the individuals of the state of Texas. And so we have people coming all the way from El Paso, which is the far corner over here, to Central Austin, and we have children. So Kat wanted me to tell you how far. So if you, hour-wise, if you're driving across the state of Texas from Louisiana to New Mexico, it's going to be about a 15 to 16-hour drive. So some of these individuals are traveling very far, and a lot of them are coming in police officer cars or vans, and they're being transported several hours into a state hospital to receive the care they need because it's not in their local community. So one of the things we're looking at is how do we create a community care in their community so they're not having to make these long travel distances. So in fiscal year 18, the Austin State Hospital operated at 252 beds, and we do have a 24-bed child and adolescent unit. And the Austin State Hospital is always full. The minute a bed is open, it's immediately taken by somebody else. And we're going to talk about the wait list. So on average, the Austin State Hospital turns a bed every 4 years. I'm sorry, 4 months. No, 4 years. 4 times per year, yeah. Excuse me. 4 times per year. And part of the reason that it's such a slow turn rate is because we have about 70 people that are actually living in the Austin State Hospital currently. There's not a place for them to leave or go to continue their recovery after they discharge the hospital. And so that's one of our initiatives we'd like to continue on in next session, is working towards a step-down system for once they leave the hospital. Where's their support after that? Approximately 95 individuals are on the wait list at any given time, and that's just for the Austin State Hospital. For the state of Texas, it can range anywhere between 300 and 400 people waiting, and they're all, most of them, waiting in a jail. So here's our steering committee. It takes a lot of people to create movement and work. We had one steering committee, which is kind of our advisory board, if you're relating it to how Colorado also created their redesign. And we had 17 key people coming from the Health and Human Services, UT Design Institute, UT Systems for our health affairs, Texas Hospital Association, our rural community hospitals, law enforcement, peer and family representatives, and then Steve Strakowski, our chair of the psych department for UT. I believe every single one of those members then was a chair for either a subcommittee or a work group. And it was key because we had all these teams meeting on a monthly basis to come together and look at the gaps and gather information and really learn from everyone and see what's working in our current community and then what areas do we need to improve. And so we have, just to name a few, we had communications, we had policy and legislation meeting monthly, we had a finance team to figure out how do we support financially the changes we want to make. We had an academic team because workforce is a real issue in Texas, and I'm sure it's an issue everywhere. But we have several rural counties, and many of them don't even have a psychiatrist, a psychologist. Some of them don't have therapists. So behavioral health workforce is a big need in our area. We also had work groups, our local mental health authorities. We had 2 key members on our group, which was a total, they covered 8 counties. But in general, there are 39 local mental health authorities in the state of Texas, and 12 of them fall within our service area that we showed earlier. We had subspecialty to have engagement on all the other subspecialties within mental health, peer and family, of course, to hear their voice and understanding, and law enforcement, because we do have our behavioral health system, mental health, brain health system is really tied to the law enforcement system currently. So I'm going to hand it back over to Kat.
So one of the things we did when we started was to lay out our core principles. And the one main guiding principle, you can find all our principles. We have a website that I'll give you at the end where you can find all this if you want to read about more of it. But the core one was people first. And I just can't tell you how many times we have invoked those 2 words in the process of this work. Every time we hit a barrier, every time a financial consideration, a change, a different need, comes up, we just say, this has to be people first. We have to serve people first. And I think it's really important when you start on your journey to decide what those principles are going to be that guide you, not when it's easy, but when it's hard, when you hit the barriers, because you're going to need them, and you're going to need to keep going back to them. When the neighborhood groups say, we don't want this in here, we don't want that, you've got to be able to say, this is about people first. I understand your concerns, but we need to take care of these people, and this is what we've got to do. So this is our core principle that I just can't say enough about how much it's guiding the work that we're doing. One of the first things that we did when the Design Institute for Health came on board with the project, and that I recommend for you too, is that we did a lot of design research to really understand the needs of the people experiencing the system. So when you put together a steering committee like we did, which I think is essential, because if you think about this, this is like one of these societal problems that there's no one entity that can obviously fix it or be in charge of it or make decisions about it. So you have to create that entity in your steering committee. But then a lot of those individuals will have a lot of opinions about the best way to fix it. They've been working and they're devoted to the system and they're trying to figure it out. But they may not actually have a lot of empathy around what's really happening with the people experiencing the system. And you need both. You need both. You need that expertise, you need that leadership in the steering committee, and you absolutely need to go and understand what's really happening on the ground with the people. So this was just a summary of the types of interviews, observational research, contextual research, everything that we did. Spent many, many days at
jails and mental health court, meeting with families all over our service area, interviewing people who had been to various both private and public state hospitals, understanding the outpatient system, understanding what was happening in schools, really looking at the whole system and hearing the voices of the people experiencing the system. We arrived at a lot of insights. We boiled them and distilled them into 8 core insights, that we used also to guide a lot of the work that we're doing. And again, you can find all that in our report, which I'll give you at the end, the URL to it. And a couple of the ones I wanted to touch on, one of the first ones was really about the fact that living with a mental health condition is lived through a process of recovery, and there are no quick fixes. This is part of what makes it so incredibly different than physical health care. And the mindset that we bring to physical health care is very different. And the system we've set up and where all of that came from, the diseases that are really hurting us and killing us today are diseases of society. And mental health is absolutely one of them. And the healthcare system, both physical and mental, that we have set up right now isn't really designed for that, for chronic conditions that have to be lived through a process of recovery. So one of the first things that we are really trying to do is make sure everybody really understands that this isn't about you go to the ER and you fix this and you go home. That's just not what happens here. I don't think it's a surprise to any of you about just how absolutely siloed, in particular, this area is. You see it all over medical care and physical care and academic medicine, quite frankly. But when you get into mental health, the siloing is just unbelievable because you have legal systems and law enforcement systems, education systems, physical health systems, mental health systems, and none of them share information. None of them were designed to. None of them have the same funding. None of them have the same objectives. You have to bring them all around the same table to attempt to figure out how to actually create something that would be a system that would be good for the people moving through it. Another theme that was just so obvious on all levels, individual up to system levels, in our system was the opacity of it. There are so many black boxes for people in not knowing how to navigate to care. Everything from a family not really understanding a diagnosis or understanding a care plan or a treatment plan, all the way through to sheriffs not knowing how to get somebody into a state hospital and not understanding how the decisions are made and not understanding who to call. And so the opacity of the system is unbelievable. So even mapping that system and starting to clarify that, even if it's not pretty, is one of the first things I really recommend that you do so that you can see what you're trying to redesign. Another thing that we found early on in our work too was just, again, you all know the stigma that's still associated with living with mental health conditions. I think in our lifetime we've seen stigma removed from a number of things. Cancer is one of the ones I think of where how easy it is to talk about it now. Not that it's ever really an easy thing to talk about, but it's really, I feel like in my lifetime I've seen that change where people didn't talk about it and now people do talk about it more openly. The rates that people are impacted by cancer are similar to the rates that we're all impacted by mental health conditions in our families and neighbors and friends. So one of the big things that we found that really needs to change is language. We find we all like to use acronyms. We like to use fancy words. We like to use jargon, and it all creates barriers. It all creates barriers for people to understanding, and it also creates stigma. So we did a lot of work, even from the initial design research that we did. We started to generate lists. I mean, the one I like to call the big three is the one you've already heard on stage: mental health, brain health, behavioral health. Which one are you going to go with? And they're all named different things. And which word are you guys going to use? They're all over the place. So one of the first things we did, I was one of the chairs. One of the subcommittees I chaired was the communication one, and we did a lot of work where I brought together all the communication leads in all those different organizations, and we did lots of workshops on taking all these words that I had heard patients, families, providers, all different kinds of folks use different language. And I was like, let's look at these and really talk about them. And one of the things we did was we had people chart them on this map. That was what they were doing in this workshop, where from jargon to plain language and from isolating to empowering. And we took each word and had all these different groups charted. And I actually, in your packet, you don't have to look at it now, I made you a blank one of these with some of the words at the bottom, so you can go ahead and start practicing where you would put them and start thinking about it. Because I actually think it sounds really simple. It's not, because like departments are set up of whether they're behavioral health or mental health or whatever they are. And I think there's a lot of language in this space that creates stigma and that creates that contributes to the problem in a way that isn't necessary. So for example, we have a list actually in our communication report of what we would recommend and what we're trying to recommend for language in our area that would work better. You'll hear us call our project a brain health system redesign. And some of that comes from the fact that we spoke specifically with people living with mental health conditions and their family members. They liked that. They liked that it reduced stigma. They felt like mental health already had a lot of stigma and behavioral health has tons, because it seems like people think it's just a behavior and it's not actually rooted in an actual brain disease, and so that it is. So we try to use brain health and mental health. It's hard to just go to brain health because that's a big shift. We looked at things like really plain language around, like one of my favorite ones is discharge plan. Like, who wants a discharge plan? Like, what does that sound like? You want a care plan? I mean, so looking at the language that we involve, it's a forensic case. It's a justice-involved case. And looking at things like that, even substance abuse gets used all the time, rather than substance use disorder. So really take a look at the language. This is one of the things that I think we have to look at. Another thing that I put in your packet for you that we did here, and this is not new, but this is a new visualization of it that's really become core to the way that we're working. This is what we call the continuum of brain health. And it literally moves from, it's for the whole system and it's for all the people moving through it. Of all the phases you have to actually think about when you're thinking about the whole continuum. So from understanding and preventing to identifying to healing and treating in an outpatient setting to recovery, and how that loop has to be maintained, because these are progressive dynamic diseases and people that have changes in their lives. Then we have what we call that's the optimal pathway. Notice that there's like no hospitals involved. The thing that is funding all this work is a hospital, but there's no hospitals in the optimal path. So ideally, we take all that money and all that work from the crisis loop, which happens when you have a crisis and you have to either go to an ED or a jail or another place that wasn't designed for a psychiatric crisis, and then you end up in an inpatient setting of, like the Austin State Hospital or another inpatient psychiatric unit. But the point is, this is the optimal pathway, and I think really thinking about, this is one of the things I put in your packet so that you guys can actually map what you have in DC for all of these phases. It's one of the things that we did is start to say, what do we have in place and where are our gaps? And then obviously this is the crisis loop where sometimes I like to say we're designing a hospital that we'd rather eliminate a need for. So, but you have to understand, like, what do you want the system to actually look like so that then what hospital do you design? I think if it were up to a lot of the sheriffs in our area, they would have had a 1,000-bed hospital, and we actually ended up recommending one that's smaller than, or it's just a little bit bigger than the current one.
So I think we have 3 minutes, so I'm going to go quickly through our recommendations that we sent to legislation this past session. One, of course, is to transform the Austin State Hospital. It needed to be changed, and we're using it as our catalyst to then change the system of care for behavioral health, mental health, brain health. Secondly, we'd like to utilize and optimize the community psychiatric beds. So all of those little hospitals that were sprouted throughout the service area, there's about 1,000 beds available any given day. Of course, we have to increase our workforce to utilize those beds, but there are other options than the state hospital located centrally that we could keep people closer to their community, which is where we want to keep them with their support system and their family and their loved ones. Redesign a competency restoration program and process. This is one we're definitely going to keep going back to in the next legislative session. We didn't get much traction on it, and it would be a lessons learned. This is a group that we really struggle to. One, they're very busy. Judges are very busy. They're not able to come to the table on a monthly basis when you're wanting to talk with them. So we're really going to enhance that moving forward and looking at how we can improve this. We would like to establish a 60-day inpatient competency restoration cap. Currently, individuals at the Austin State Hospital for competency restoration can cycle through and go through almost up to 120 days. We've found research that shows competency restoration can be completed within a month. And so we'd like to recommend 60 days, which is a comfortable medium we think everyone would be happy with. It also saves a lot of funding, about $26 million that we could allocate into other areas of the service and the system, rather than it being in the COMC restoration in the inpatient setting. And then increase our residential care and supportive housing capacity. This is something Texas lacks. We need a place for individuals to go after they've left the hospital to continue care. And I don't think we've touched base on this, but what we're looking at is a platform. So Austin State Hospital sits on about 95 acres, which is centrally located in Austin. And so we'd really like to, one, of course, increase the hospital to be a much better facility to provide care, and then looking at creating the colorful picture with the greens and the blues, areas for partnerships to come in and create an area where we are creating the best care, and we can then share that out to all of the service areas. So it's filtered throughout the 75 counties that we are involved in. And I'm gonna fast forward, and we can touch base on these later if we'd like.
Yeah, just to wrap up, first of all, I kept referencing one of the things we also want to do was to, around that finding around opacity, was to be really transparent. So our entire report that we delivered to the legislature and all the appendices is available at ashredesign.org, which is another thing that doesn't usually happen. I'm like, we're a public entity. We should put this out here. Other communities should learn from all the work and research that we did. So there's a website up there, and it's all up there. You can look at all of it. Sydney already mentioned a little bit of what's up next for us. We're going to go back and get the rest of the funding. There's a lot of policy and funding work that we want to do to actually look at building out that whole continuum in a better way. The hospital cannot solve all the problems of our system. We will start building that hospital facility, looking at partnerships so that we can build out that whole continuum and the optimal pathway right there on that campus. And then also, look to just keep building it. It's going to take a long time. To Barbara's point too, like we're looking at this like this is decade plus. I mean, this is work that will take a long time, especially with the way our legislature meets. But some of the hindsights for you all, and these are just questions that we were like, what would we tell them if they were just starting, since you are, is first of all, what's driving your moment to redesign? Like what's the impetus right now? Because really think about seizing that. For us, Design Institute, we call that a lot of times the Trojan horse. Like the Trojan horse to us getting at the system is this hospital redesign that the legislature wanted to fund. And so we're using that as a way to get at the whole system. It's not just about a hospital. Map your current state. We talked about that. Get all your sectors together. Figure out who they are here. I'm fascinated by District of Columbia. How does that work here? You guys aren't a normal state. Really interested in what that looks like for you.
Why do you say that?
I don't know. I'm from here. I can do that. Understand the system from the perspective of the people experiencing it. Don't leave them out. Make sure you understand that. Let that be what you thought it was, or let it surprise you, but take it for what it is and really honestly look at it. Cross-pollinating between academic, public, private, and community, I think is super important too. And it looks like you already have that starting to happen here in the room, which is great. You're already looking at analogous models and best practices. And then obviously, can't tell you enough, persevere with urgency, patience, and creativity, which I think you can learn from Colorado too. So you're going to need all three, and you have to keep going. You're going to hit bumps, and that's what's going to happen. Okay, finally through. We can do questions. Yeah.
Thank you.
Thanks. Yeah.
So we're doing a beautiful job on time. So we've still got 15 minutes for break, so we can really get into a few questions here. This is such an awesome example of what design looks like when it is really connected to some deeply aspirational motives. And so my question is not the least bit critical, but really just wondering, looking back at your steering committee, and again from the perspective of a child and family psychiatrist, unless I read it wrong, there weren't any members of your steering committee that live and breathe children and families. So
it's not obvious, but they're actually
they're in there? Okay.
They are there. So our subspecialty had children, and it was ran and still ran by Dr. Jim Baker, and he is a child and adolescent psychiatrist. And Steve, Adolescent, our chair. So they were there. If we would have created the list of the 117 people that sat on all the committees, I could have wordsmithed the the names out of their titles, but yes, we did have members from child and adolescent psychiatry.
You can imagine why I ask. 'Cause, I mean, it's really in many ways a design question because so many of the systems we're trying to get out from under were designed to serve adults in ways that aren't working so well for adults anymore either, but they're certainly not working for kids and families. So how did those voices then impact your design process to date? Those voices that do represent the perspective of kids and families.
So yeah, and there's actually a specific report we did on children and adolescents that's in there. That's one of the appendices you can look at too, because we really looked at the need there. You know, I think that part of what we found was that the local mental health authorities, which again, I'm not exactly sure what the equivalent is for DC of those, but we have 12 in our service area, and they are really finding the children and adolescents the care they need closer to the community. So from a state hospital system perspective, which we're actually thrilled that that is not where they are coming, because it's not where they should be coming.
Right.
And so in some ways, those are the groups that are taking a closer look at that. And we did do a lot of work with that. One of the things I would say that could be a model for you too, it's referenced in our report, but Travis County specifically has a deferred prosecution pathway for kids on their first offense with a mental health condition. That it could be a really great model. I don't know what you have here, but it's one of the only counties in Texas that set it up, where if you have a mental health condition, your first conviction, and because I sat in that court a lot, it's more than the first conviction, but they try to actually not prosecute you, but get you the mental health services you need. Most of those kids are coming from a lot of trauma and really need that more than they need to be in juvenile detention center. So that's another model to look at with, it's called our COPE court, and it's in the report, but you can see it. That's a model that you might want to look at too. So I don't know if I answered your question, but a lot of what we're looking at on the campus is also how we can serve that large service area. So the child service area is the largest that we have. It's 75 counties, and certainly one of the challenges we have is actually having psychiatrists in all those counties. There's many, many counties of the 254 counties in Texas that do not have a psychiatrist in the entire county. So telemedicine will play a big role, and looking at the center that we build on this campus, using a lot of the new folks at our psychiatry department to provide diagnoses and care plans and work with rural providers will be a big part of what might happen on this campus too, to serve kids especially, but all people, really.
I'm glad you mentioned. We actually have a couple of folks in the room that have helped to develop some of the alternative pathways through juvenile justice here.
Yep.
So
Good.
we may hear from them later. Alan.
Sure. Hi, Alan Isawi. I'm with the Laurie Center for Children's Social and Emotional Wellness here in the DMV. Quick question, did you all engage the business or corporate community in any way around this whole conversation to get you to this redesign?
Yeah, that's a good question. I would say where business and corporate is coming into play the most, and they haven't had, well, it's not true. They have had a voice through a lot of our groups, but where they're coming into play the most is in the partnerships that are coming up for the campus, and some of the services we want to have there, and that's really where that's coming into play the most.
I think that's going to be in the future and next to come when we redesign the platform and the campus. What partnerships can we have here? And we did have Texas Hospital Association members on our team, and they would be included in that. But they're helping us find partners for the campus to help us in that area. Yep.
Other questions? Yeah, Yavar.
Okay. Yeah, Yavar Mogimi with Mayor Healthcare TAS DC. I really like the continuum design that you did. It's really nice, and the language is very well thought out. So I was curious about the intervening category there, because I think that's an area where we have challenges in terms of really providing alternatives to hospitalization in crisis beds or what have you. And since you were talking about the bed shortages you have there too, I was just curious if in this design process there was any new sort of opportunities for interventions that avoided hospitalizations.
You want to talk about stabilization crisis?
I'll let you talk.
Okay. I mean, we have, so one of the things is Travis County is more resourced and has more than a lot of the counties we're serving. So that was one of the things we had to do, was kind of do a typology across the counties. But in Travis County, we did just actually manage to build a 48-hour stabilization center where people can go for crisis and actually be stabilized and then directed to the care that's appropriate for them, whether it's inpatient or whatever it's going to be. We also, so part of the plan that we had put in place longer term for is around having more of those types of units, as well as respite care units around the service area, because you really need those out in the community. So one of the things that you'll see too in the packet, and if you look at our report online, is that we use the continuum to build what we call a blueprint of care. So if we could design the perfect system, which we know we won't be able to, but it's still worth saying what would we design for each of those stages. And you can see, I think we included a high-level version of the blueprint. There's a more detailed one online. But in the blueprint, you can see what we recommended for that as well, because going straight to inpatient psychiatric care or your care in a jail is not always the right path. And a lot of times you need, crisis stabilization. Across our counties, a lot of them have mobile crisis outreach teams, but not all of them do. I mean, a lot of them have a lot of work to do to even, apply those mental health workers to go out with, whoever the first responders are and actually assess if it's a mental health crisis rather than something else. If you want to add anything.
I would say that our local mental health authorities, the 39 that we have in Texas, are the ones that are supporting the intervening and doing their best that they can with the funding they receive. So we have 48-hour crisis units, probably not throughout the whole state of Texas, but a good amount of our 39 LMHAs do have them. So I can speak to child and adolescents. Our local mental health authorities, again, do have them. We call them respite support systems, where the child would go into respite and can be there for up to 48 hours. Oh, I think.
Yeah.
Hi, good morning. I'm Linda Elam with AmeriGroup DC. And it just so happens yesterday I was at a meeting at AARP about dementia, so I'm kind of doing the whole lifespan. But I'm intrigued by the language conversation, because for the awareness of the group too, the dementia side is also embracing brain health as a way of addressing stigma and engaging people in care and moving them toward healthier behaviors. And so I'm really interested in the brain health units in the construction and the framework that you're using around that. Is it including the whole lifespan and also including things like addiction, traumatic brain injury, and so forth?
Yes. Okay. Yeah, they're right. So we do, first of all, that's one of the first things we talk about, is that we do consider substance use disorders to be part of brain health. And that's, I know that some groups don't put those things together, but we absolutely do. We look at the whole continuum. So the whole age span. There are, in that map that Sydney showed you, the specialty care, which was in the hashtag building, is actually where a lot of the folks are. I mean, in a lot of ways, those are folks who have mental health conditions and diagnoses for sure, but probably other intellectual disabilities and or physical complex medical challenges too. And that unit is set up specifically for that. That's actually one of the things we're rethinking about how you actually build that. One of the recommendations we made back to the legislature was that the plan that we recommended was actually, okay, spend this much to build the hospital, but build a residential unit, because really if people are going to be living there with really complex and varied needs, they need a different type of space than like an ICU bed, I mean, essentially. So they need, actually thinking about that. What do people need to live with all different kinds of situations? So the older folks and a lot of the folks experiencing dementia and things like that are part of the plan here too. Especially in the Trojan horse, the state hospital that we're redesigning, that's letting us get at all of it. Specifically, the people that are in that hospital have to have at least a mental health condition, and then they may have other diagnoses as well.
Hi, my name is John. I'm from the Office of the Attorney General. My question is whether early intervention can be effective without buy-in from families. And the question is really for anyone who wants to answer it. What have you guys done about that? Thanks.
So I mean, what I would say is part of why when we built the continuum, we have that beginning piece that's about understanding and preventing. That there's, you know,
not there yet.
That's putting that on there and recognizing that is a big challenge, because that means everyone. This is like this is not just people with a mental health condition that start getting into the levels of care that are needed in the continuum, but understanding and preventing is everyone. And this is what I meant about a societal problem. I think really having people understand that 1 in 5 people anywhere in this room, 1 in 5 are actively experiencing a mental health condition right now. Does not discriminate by anything in this room right now. You know, that's what we have going on. Any room you're in, and really getting people to understand that and understand what's really needed to get brain health, mental health, whatever you're going to call it, to the table early, so that it's something we talk about, so that it's something that's not so stigmatizing, so that it's something people seek care for, so that we have avenues for them to get the care they need, and not having it be this, you know, lumpy rug thing that we don't talk about, you know, is just part of what has to change. So absolutely, if you want evidence-based models of early intervention, you know, making a big difference, those are absolutely there as well. But that's the high-level answer I can give you for now. Part of what we want to do, we haven't gotten to really designing that part of the continuum yet, but that's part of what we want to have on the campus. So that's the long term.
And just putting my Ascend hat on for a second, I think one of the things that oftentimes is missing from existing efforts on the family side with early intervention are adult-focused supports and strategies. And part of engagement is recognizing brain health challenges that may be impacting parents and other adults and families and family systems that impact their abilities to engage with efforts at our attempts at engagement. I think the burden is really on us to do, the onus is on us to do a better job of really being multi-generational in those early intervention supports. And early intervention is not just about a 2 or a 4-year-old. It's about the whole system around that child. I think we have time for one other question. Seema. Oh. Well, we'll squeeze in 2.
My name's Carrie. I lead the policy and advocacy team at PAVE. And I appreciate what you were saying.
Say what PAVE is?
Parents Amplifying Voices in Education. We do ed policy in DC. So I really appreciate what you're saying about the redesign and really unpacking the system and reimagining it all. And I think that's totally right for what we're trying to do in DC. And one of the things that our parents that we worked for have been asking for is, when you think about building mental health professionals in DC, what does the workforce development and the pipeline look like for that? Because as like we've all talked about the need and the redesign and the reimagining, but we need the people to do that, right? People first. So I'd be curious as to what you're doing to build that pipeline of workforce development.
Great question.
So we had an academic work group on one of our large steering committees that we had. And who we brought to the table were all the psychiatry departments from all of our universities, community colleges, and met and discussed what we needed to do to create and increase our workforce. We haven't been able to start any of those because we go through sessions. So we will be bringing that team back together and looking at what areas we can change, either in how they're able to get licensed. So depending on their licensure, and are they able to provide care at different levels, partnering them with other specialties to provide education, and looking towards how we can build them more. And there was one thing and I forgot it. I'll have to come back. I'm going to have to remember it. I just thought of it. I apologize. I'll have to remember it and catch up.
I can speak just a minute, because I think, you know, we had a workforce work group, and again, I would put all $65 million into workforce development. Oh, you can't hear? Oh, did I turn myself off? So And I think we got stuck in the politics and fiefdoms and you know, academic institutions being more interested in 4-year pipeline versus 2-year certificate. So we got really stuck in the politics of it all. And we finally realized it is a quantity and a development and a support perspective that we need to have, and we need to get past the politics and just start developing the resources to prepare behavioral health providers. So we have a certificate that we've created that now enables them to negotiate in different ways with insurance companies. Even if the network is full, they can identify, I'm a prepared integrated behavioral health care specialist. It's a very slow start. We also have had state appropriated funds for our primary care office to increase reimbursement for education loans for behavioral health providers in our rural areas. And then looking at our LCSWs that are in training that require 2 years of supervision before they can practice independently, how that's going to, you know, how we can change that. And one of my last things I'm trying to get over the finish line before we leave is funding to continue to support that certificate and a focus on behavioral health workforce. And I think it will not get any better if we do not reimburse behavioral health providers more. Full stop, you know, bar none. On the commercial side, on the Medicaid side, we have a reimbursement issue. And so that's definitely something that I think we have the appetite in our region, in our community today that we didn't have 4 years ago. I couldn't even say that then. But that is absolutely something we're trying to just get some funding and some focus from the governor's office that yes, this is an area that's a gap. But we have this certificate that now our 4-year University of Colorado is like, well, maybe we could help host that for a little while and evaluate it and see if it has legs. So anyway, it's not easy, and we got stuck in the fiefdoms of psychiatrists, psychologists, NPs, social work.
We don't have that here. Can we, Seema, will you close us out, and then we'll go to a break?
Sure, thank you. Thank you so much, and congratulations on your vision and your work. Perhaps in Washington, D.C., our Trojan horse, or maybe one of our Trojan horses, could be violence prevention and public safety. And I was wondering if any of your work intersects with that work in your jurisdictions, or if you know of work like that elsewhere.
Just this past legislative session, we had Senate Bill 11, which became several entities into one, merged. It has mental health on it, and one of the key aspects is school safety. We had a shooting in Santa Fe, which is actually in the Austin State Hospital service area. And so once that happened, Governor Abbott went straight to another steering committee. I don't quite know who was on it, but developing school safety policies and interventions that they could provide, and they incorporated mental health within that. So I do know that's coming out in this next, I believe it starts in 2019 this fall. Along with that, on the same one, they tied together a Texas Children's Mental Health Consortium, which has all of the university psychiatric leaders coming together on I believe it's a quarterly basis, to develop initiatives between primary care and psychiatrists to help educate primary care on mental health for children and adolescents. So that is coming out.
Yep. And then in the hospital that we're building, which is a little bit different, that's probably more relevant to what you guys are focused on, but there's a number of things that we've been studying through design and architecture around space and healing design that have to do with preventing and reducing violence in that setting. So there's a lot that we're doing, even for an inpatient setting and a healing setting, to look at how to reduce violence when you're at that part of the crisis.
We're having a particular bad week in DC related to public safety, so I think it's on a lot of people's minds, and so I think it's a great example of how we might translate some of these other design perspectives into something that's really highly locally relevant.
Yep.
So with that, really want to thank our 3 out-of-town visitors. And welcome home too. So we're gonna take a break for coffee and a snack, and then reconvene and hear from 3 local leaders talking about what's happening and what could be happening in DC. So we're gonna get really concrete and specific. If anyone has to slip out now, I just want to make a quick plug that this is, as Lee said at the outset, this is the first of 4 of these convenings that we're going to put together. There are going to be additional ones in the fall, winter, and spring that are going to have more specific topical foci on parents and early childhood, on adolescents, emerging adults, and addiction, on schools and school mental health. And so there's a lot more to come. We do have a date for our next convening. Just want people to calendar November 12th. It will be at the ARC across town. A lot more to come on that soon, but please put that on your calendar with a lot more anticipation than we gave you for this one. So have a good snack, and we'll see you in a few minutes.